Yes, okay. Acute coronary syndrome. I think we all know it, right? Yes, here it is. We have like a PDF and we have a presentation. We can talk a while here. This is angina and this is unstable angina. Decreased mortality, no. Here we go. So I will share the other thing. Yes, acute coronary syndrome. What do we mean by acute coronary syndrome? Okay, we do mean أرميا المشكلة بتاعته أرميا. Okay, so we have three conditions of acute coronary syndrome. We have unstable angina, STEMI, and non-STEMI. What is the difference between three of those? For unstable angina, as we already mentioned, there is a partial rupture in the artery. Okay, doesn't cause permanent damage to the heart. Usually, yes, there is no permanent damage to the heart. Okay, but there is like a rupture in the artery, for which, as we said, the sequela, what will happen afterwards, there will be a thrombus formed here. There will be a thrombus. Afterwards, there will be like an partial occlusion in the artery, and etc. This is the main cause of the unstable angina. While we have in STEMI is the most severe and critical case, and it's fatal. If it's not treated promptly, it will cause may lead to death. Okay, so for STEMI, there is complete occlusion of the artery, like that, as you see here. There is a complete occlusion of the heart of the artery that will lead eventually to the myocardial infarction, or like an severe injury to the cardiac muscles. Okay, what are the complications of STEMI? Do you know what are the complications of STEMI? This may lead to several conditions. Like what? Complications. Because here it's severe.
Heart,
The
heart failure.
artery is completely occluded. Yes,
Heart
heart
failure.
failure, or what we call left ventricular dysfunction,
It is the main one.
which will lead, yes, which will lead eventually to systolic heart failure. Yes. Okay, so yes, heart failure may cause arrhythmia as well, pericarditis, and etc. Okay, okay, this is complications of the STEMI. The non-STEMI, okay, is milder than the STEMI. As you see here, there is cholesterol buildup or cholesterol plaques in the artery. There is a narrowing in the passage of the blood here, as you see, but there is no complete occlusion. Okay, it's a partial occlusion of the artery. Okay, can cause damage to the heart, yes. May it cause a permanent damage to the heart muscle, yes, as well. It may cause a permanent damage. Okay, so that's it. Is it clear the difference between the three acute coronary syndrome causes? Okay.
Sir, please, for the unstable angina, a rupture damage for the artery, and then after the rupture, because it is here, it is inducial injury. So the plaque happened.
مش فاهم.
Okay,
What did you say?
again for the unstable angina.
Mm.
You see in your picture there is a rupture in the artery. Rupture.
Okay.
So it is an injury. After this happened, there is a plaque, there is aortic plaque happened. Sorry, it's acute plaque happened.
Usually the plaque is already there. The plaque, the cholesterol plaque is here. Okay, what will cause the injury, the rupture here? Usually it will be the plaque, the cholesterol plaque like that. It will cause the rupture to the artery. Okay, as long as there is a rupture, there will be a thrombosis technique, right? Thrombosis pathway. So we will have a thrombus here beside the plaque. So you will have a plaque and thrombus. There will be a risk more and more to get occluded, the artery occluded here.
Okay, but in the stable one, you said that in the previous section, that
Mhm.
is the plex is a staple, not rupture.
What is stable?
In the stable angina, you said that the plex is stable, don't cause rupture of the artery. That's
This
because
is in
that's
staple
why
angina.
I know.
This is in stable angina. Here we are talking about unstable angina.
Yes, yes, I know. The difference it is the stability of the atherosclerotic plaque. I am right?
Stability of what is the
The,
main clinically what is the main difference between unstable and stable angina?
okay. For the unstable angina, it can be happened in anyone in any time because of the unstable of the thrombus itself.
Okay.
But in the stable one, there is
The
a
rupture
stress.
can happen. Let's say the rupture can happen at any time, right?
Yes, yeah.
Okay.
But
Okay.
in the
What
stable
about
one, there
the
is no
relief?
rupture.
What about relief? Hmm?
What about what? I don't hear.
The symptom relief with rest, with the rest.
Yes.
There will be a symptom relief with the rest in unstable angina.
No.
Mhm.
No.
Okay. So I think I think this is the main reason for calling it unstable angina. Because with the rest, there will be no relief. While with the stable angina, when you will be rested, you will be relieved.
Ah, okay.
Okay? But with unstable, even with rest, there is no relief of the symptoms.
Okay.
Okay?
Thank
Maybe
you.
because of the thrombus, yes, as you say. Maybe because of that. But this is the main difference: the symptom relief and the nature or the origin of the ischemia. Okay, here it's because of the thrombus and the consecutive thrombosis that will happen here, while in the other one, in the stable angina, it's because of the narrowing of the artery. Maybe because of the plaque, yes. Maybe because of the spasm, like Brenn's metal. Okay, and that's it.
Thank you. Okay.
We have other differences between STEMI and non-STEMI or non-ST elevated acute coronary syndrome. We mean here by non-ST elevated acute coronary syndrome, the non-STEMI and unstable angina. Okay? Yes, for diagnosis. What about the diagnosis for STEMI and non-STEMI and unstable angina? Diagnosis for STEMI is it's based on ECG, right? Or it's based on biomarkers.
Both.
I think three of them, one of the diagnoses, it could be the ECG, because the different on the, according in the STEMI, it's the elevation of the ST, while non-STEMI, it's not elevated. On the other side, it's lower, while unstable angina, it's, I think it's inversion of the T wave.
Okay. Yes. Inversion of the T wave could happen as well in non-STEMI. Non-STEMI, I believe, yes. Okay, so for STEMI, usually diagnosis is based on ECG, as you say. There will be ST elevation. If we ever notice the ST elevation, so definitely it will be STEMI. Okay, if there is no ST elevation or T wave inversion or even ST inversion, there will be, we have two options here. Either non-STEMI, either unstable angina. What could differentiate between the what could differentiate between the two diagnoses is the biomarker, the troponins and the cardiac biomarkers. In non-STEMI, you will have high or elevated biomarkers because there is infarction, there is myocardial infarction, there is injury in the heart muscles. Okay, there is injury happened, so the troponins will be high. While in unstable angina, the injury is not yet there. Okay, so in unstable angina, you may have mildly elevated troponins or absence of any elevation of the troponins. It's high sensitive troponins. Okay, this is a difference. So here the diagnosis in unstable angina usually based on absence of markers. Okay, in non-STEMI based on the presence of biomarkers. In ST based on the elevation of ST segment. Okay, in the ECG. That's it.
Doctor, after your excuse, I read something very amazing. They said that for the troponins, it is elevated to moderate to high in the STEMI and the non-STEMI, and 1/3 of the patient with unstable angina, it is elevated.
Yes, as we say.
Yes.
Could be mildly elevated, yes. I say that. Either
I
on absent or mild elevation of the troponins. Yes, in unstable angina, yes, and it could be mildly elevated. Okay, but in STEMI or non-STEMI, it will be high elevated. Moderate to high, as you say. Tamam? Clear?
Yes, clear.
Okay. Maya. Perfect. What about the emergency treatment for every condition? Okay. For emergency treatment, or what we call stabilization phase, when the patient is firstly admitted to the hospital. Usually we focus on two things: to eliminate the ischemia he has and to stop blood clots. Okay, eliminate ischemia and to stop blood clots. Okay, what medications we can give? We can give nitrates, antiplatelets, blood beta blockers, calcium channel blockers, ACE inhibitors, anticoagulants as well. Okay, all of these medications we can give either to eliminate ischemia or to stop the clots or further clot formation. Tamam? Okay. Of course, we can give morphine and we can give oxygen as well to control pain and to eliminate ischemia. Tamam?
What is acetyl salicylic acid?
Hmm?
What is the acetyl salicylic acid? We should make Mona first.
Antiplatelets.
Oh, thank you. Sorry.
AP, antiplatelets. تمام.
Okay.
Okay, the same thing here. Nitrates, antiplatelets, beta blocker, calcium channel, ACE and ACE. Oxygen, morphine. So for the stabilization phase, or once the patient is admitted to the hospital, usually you will have the same technique. You will give him high dose of aspirin, and beta blocker, nitrates, and etc. You will start by sublingual nitrates. If it's not effective, you will give intravenous nitrates, and you will go for beta blocker. It's not in, if there is contraindication or anything, you can go for the calcium channel blocker. Anticoagulants you will give for all patients, usually for all patients. Okay, which one is the preferred anticoagulant here in this setting? In acute coronary syndrome, which one?
Enoxaparin.
Correct. Anticoagulant is not aspirin.
You mean anticoagulant for what? For which one?
It's enoxaparin. I'm answering Iman or Eman. She said aspirin. Aspirin is not an anticoagulant.
Okay, so enoxaparin is the preferred agent in a low molecular weight heparin. Hello.
ايه نهى انت سامعه حاجه؟
لا مش سامعة أي حاجة. إيه اللي حصل تاني؟
الظاهر دكتور محمد طلع بره.
مجرد ما دكتور محمد بيختفي نهى مونتريال بتبقى الهوست، معرفش ازاي.
نهى مونتريال بتبقى ايه؟
تبقى الهوست.
يا سلام.
بيظهر قدامي كده نهى مونتريال از هوست.
يا ما اعرفش، ما بيظهرش عندي حاجه.
Yes, شباب. Sorry. The connection. Yes, I have a problem in my internet connection, I think. تمام. Okay. So the preferred anticoagulant, if the create clearance is above 30, is enoxaparin. If it's below 30, it will be unfractionated heparin. Okay. تمام. Okay. So this is in stabilization phase. What about the post-stabilization phase? First thing to do is angiography. And for STEMI, of course, it will be PCI. Okay, PCI, if available, it will be the first choice. Okay. We can use the pharmacoinvasive treatment with fibrinolytics could be considered as an alternative if the PCI is not available, or if the patient is afraid from invasive treatment like PCI. He may recommend, he may prefer like drugs like fibrinolytics. So these are the two situations where the fibrinolytics are preferred. When the patient does not want to go an invasive procedures like PCI, this is number one. Number two, if the PCI is not available. Okay. This is a post-stabilization phase in STEMI treatment. What about the non-STEMI? First thing as well is the angiography. And you calculate the TEMI score. Why we calculate TEMI score here? For what reason we use Stemi score?
Risk of death.
To know if he a high risk patient or not.
High risk patient for what?
Death. Or transient ischemic.
Mm-hmm. Okay. This or recurrence. Okay. I have a slide here about that. One moment. I mentioned the recurrence. We use it for what? For
The TIMI score, sir, the TIMI score, it is the risk score in non-STEMI or unstable angina.
For death and the recurrence of an ischemia.
Thrombolysis in myocardial infarction risk score. Thrombolysis in myocardial infarction risk score in non-stable or unstable angina. That's it.
here it is, my friend. Okay. Analysis of data from Stemi found that 7 variables represented independently predictive of outcome in patients with unstable angina. Yes, patient with. Okay, usually we use it. Yes. Here it is. Use it to decide should we go for the medical treatment or for the PCR, for the invasion, to reduce, to decide on the risk. Is it a high risk patient or no? We have 7 criteria here on the TEMI. Okay. I summarized them like 0.5. This means if you have more than 0.5 millimeter deviation of ST segment on presentation, this means 1 point. Okay, if your patient has two episodes during the last 7, where is it? Yes, 2 episodes during the last 24 hours here. Number 3.
Dr. Mohammed, we cannot see your slide.
Ah, really? You cannot see it?
No, we see still the table of STEMI, non-STEMI.
Sorry. One moment. You can see it now, right? You can see it now?
Yes.
Okay, so here is the TEMI score. 0.5, 2, 3, 7, 50, and 65. These are like a summarization of the
Voice, Dr. Mohammed, your voice is not there.
Yes. I'm back. معلش. So can you hear me?
Yes.
Yes.
Okay. So this is a STEMI score. I will be back here. So as we said, we use STEMI in, the TEMI score in non-STEMI and unstable angina. So we calculate the score and see if the patient needs revascularization or what. Okay, we can see that the patient is high risk if he meets one of the following. He has positive cardiac enzyme, ST segmented changes, TIMI score more than 3, recurrent ischemic symptom, heart failure, hemodynamic instability, and etc. Okay? The same thing applies to the unstable angina. Okay? So the post-stabilization phase here could be a little bit different. Okay, we privilege the PCI in STEMI, while here we make the TIMI score calculation, and then we decide if the patient needs revascularization with the PCI or even with cabbage or no. Or we can manage him only medically with some medications and that's it. Okay? This is a post.
Excuse me doctor, I couldn't catch. احنا بنعمل ايه دلوقتي؟ يعني أنا I calculate the TIMI for what? To know if this patient eligible for CAPG or PCI or what?
انت بتحسبي التيمي او في النون ستيبل والستيبل انجل.
تمام.
عشان نشوف البيشنت ده هل ممكن نعالجه بالدواء بالادويه with the medication only or
okay.
we
PCI.
Yes.
Okay.
Cause in non-STEMI and unstable angina, as we said, the risk of the permanent damage to the heart muscle, we can say more or less it's lower than the STEMI. Okay, so we can manage the case medically without the invasion. While in STEMI, the PCI is the first choice.
Yeah, okay.
Recommended one. So more or less, we have to go for the PCI in STEMI.
So sorry, what is the meaning of angiography?
Angiography is like you can say like أشعة اللي جوه اللي بيصوروا بيها
زي السونار بس على القلب يا نوح. زي السونار بس على القلب.
Yes, it's like yes, it's something like a radiation or like X-ray on the arteries.
Okay.
Like angiography, yes, exactly like that.
Doctor, doctor, please, I am confused about not what you said, but but about the difference in durations about the PCI and the fibrinolytics in the stem. Door to balloon like that. It's very nasty time for me.
For fibrinolytics?
Yes.
For the PCI.
Hello.
For the PCI.
Hello. Doctor.
Yes.
Hello.
يا أرمي يا سامعني؟
لا مش سامع حضرتك. لا.
Okay, this is the time at which the patient should be admitted to the operation room to get the procedures. The fastest and the shortest, the duration, the best for the patient's safety and his heart health. Okay, so for the fibrinolytics, you can use the fibrinolytics no later than 12 hours after the onset of symptoms. No later than 12 hours. But usually it's most recommended within the first 3 hours of the symptoms. And in some evidence, it's up to 6 hours. Okay? The later, yes, if you delayed more than that, the damage will be there, of course, for sure. Okay, the more will be the damage. Okay, so كل ما كان أسرع كل ما كان أحسن. Fibrinolytics. So after beyond 12 hours, you cannot give the fibrinolytics. 12 hours is the maximum, is the latest duration, after which you cannot give the fibrinolytics. For the PCI,
yes,
Okay, you can go up to I think you can
90 minutes.
tell 90 minutes is the urgency. It's time to balloon. It's door to balloon. This means that you have to go for when the patient gets from the door to the balloon should be 90 minutes. It's like it's like a measure of the quality of the hospital. You have to give him the stabilization phase medications. Like you have to give him nitrates, make the diagnosis, and give him the beta blockers and the antiplatelets, everything within this 90 minutes. Afterwards, he has to be admitted.
الو دكتور صوتك اختفى. الو 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 نهى سامعاني؟
نعم أيوه.
مم.
نعم.
هو الصوت اختفى يا نهى مش كده؟ اختفى
هي
من امتى بقى؟
هي
من
شمس
اول
فيه.
ما
نهى Montreal is the host now.
Yeah, I'm the host. We can end.
هو يعني ايه هو يا جماعه يعني ايه كلمه الهوست دي؟ يعني بيعمل ايه يعني؟
يعني
I
هي
believe
اللي
I can
متحكمة في
end the
الميتينج.
record. Yeah.
بيتحكم في طيب ماشي، مش اي حد يتحكم في
هي
الميتنج.
هي بس شمس فين؟
الشمس غابت الساعه 8.
القمر طلع.
يا شباب.
دكتور
اوكي معلش.
دكتور بعد اذنك، كلمه دور تو نيدل او دور تو بالون ده معناه من ساعه ما المريض يطلع من بيته لغايه ما يخش المستشفى، لغايه ما يوصل المستشفى، لغايه ما يخش الاوبريتنج روم.
ما يدخل المستشفى.
يعني
دور
لما يخش
لما يدخل
المستشفى اول
المستشفى.
حد يتعامل معاه. انا كده فهمت.
Door to balloon, it means once the patient is admitted to the hospital.
لما يبداوا يشتغلوا معاه في البالون، مظبوط كده؟
He should take everything. He should be managed with all the medications, and he should be done with the ECG and the testing and everything.
يعني يبداوا
Afterwards,
يتعاملوا مع المريض جوه المستشفى، ده الوقت اللي يبداوا يتعاملوا معاه.
مش تعاملوا معاه، هو اول ما يدخل. بص، هو دلوقتي واحد جاي بيستمي ده توب ايرجنسي.
ماشي.
اوكي، اول ما يدخل المفروض الريكومندد بيقول لك 90 دقيقه في خلالهم تكون خلصت كل حاجه، عملت الاي سي جي وعملت كل حاجه وعملت النايتريتس واديته نايتريتس واديته كل حاجه، وبعد كده تدخله على الريفاسكولاريزيشن لو عايز، لو البيشنت عايز ريفاسكولاريزيشن او بي سي ار.
تمام
اوكي، ذاتس ات.
تمام تمام. طب سيادتك قلت حضرتك قلت ان الفايبرينولايسيس خلال معايا لغايه 12 اور. كويس. طيب البريفيرد
No later at the worst. This is the worst case scenario.
I know.
Okay, up to 12 hours. The most recommended is within the first 3 hours.
تمام.
The later
طيب.
you will give him the fibrinolytics, the worse will be the damage.
البي سي اي كان مكتوب في التي سي ان هو السيمتومز ديوريشن اكتر من 3 ساعات. انا مش فاهم دي.
For what? For the PCI or
البي سي اي بريفيرد لما يكون الدور تو بالون اقل من ساعتين، يعني يعني هعمل يعني خلال ساعتين هحط له بالونه اكتر من ساعتين، ادي له فايبرينوليتكس. كويس. وموجود كلمه انا ما فهمتهاش، سيمبتوم ديوريشن اكتر من 3 ساعات.
ايوه، من اول هو جات له السيمتوم من امتى؟ من اول ما اشتكى من الوجع. The first sign.
يعني لو اكتر من 3 ساعات بيفضل البي سي اي.
When he felt for the first time the symptoms, like if he got the attack since 2 or 1 hours before his admission to the hospital. Okay, But for as much as I know, as much as I remember, for the PCI, you can still give it up to 24 hours from the symptom onset. Okay, it's not like the fibrinolytics. For fibrinolytics, it's up to 12 hours. Okay.
تمام
تمام. Clear.
تمام ميرسي كلير ميرسي.
Okay. Yes. We have some other differences, like in clopidogrel, for example. The loading dose in STEMI should be from 300 to 600, while in STEMI, usually it's 300. In non-STEMI, excuse me, it's 300. Unstable angina is 300 as well. Okay. If there is a high risk of bleeding, you can omit the clopidogrel dose in unstable and non-STEMI. Okay. Clopidogrel is the preferred agent if you treated the patient with thrombolytics. If you gave him thrombolytics, not PCI, the preferred agent will be the clopidogrel, the preferred antiplatelet. Okay. Anticoagulants, as we said, enoxaparin is the preferred. Okay, no need to give the anticoagulants after successful PCI. For in STEMI, you should give the anticoagulants with the fibrinolytics for the minimum of 48 hours. If you treat the patient with the fibrinolytics, you should give the anticoagulant at the same time for up to 2 days.
But I think in STEMI, unfractionated heparin is most preferable than the enoxaparin. The enoxaparin is alternative to the unfractionated. Am I right? I think it's unfractionated heparin for 48 hours. After PCI. Hello. Anybody here? Okay.
ايه يا نهى انا سامعك بس الخط قطع عند الدكتور. هي شمس مش موجودة. شمس لا شمس موجودة اهي. وانا اللي بتكلم وانت اللي بتسمعي. يا رب يعدي الامتحان ده على خير بقى، انا زهقت.
المفروض هنن يبعثوا لنا ايميل يحددوا لنا اي يوم الفحص.
لا مش دلوقتي خالص.
I think you're gonna choose 2 weeks or no 4 weeks before the exam.
من قبلها ب3 أسابيع.
اوكي.
بيبعتوا انفيتيشن يعني.
ان شاء الله يكون بمركز هالمره ما نصفي اونلاين.
لا انا طول الوقت امتحنت في مراكز، ما امتحنتش انا في البيت.
انا المره الماضيه صار اونلاين، قبل بيومين غيروا على الاونلاين.
انت كنت هنا في مونتريال وامتحنتي اونلاين؟
اونلاين يا لانه مو صار عندنا شو بسموه الحجر الليلي الكوفرفو الكيرفيو، فكان فحصي المساء قام التغى وصار اونلاين.
وانت امتحنت؟ هو انت مش امتحنتي؟ هو مين اللي بيتكلم؟ نهى مونتريال مش كده؟
يا
مش انت قلتي دي اول مره ليكي تخشي يا نهى؟
عم بحكي على الايفالويشن.
ايفالويشن يا شيخه. وامتحنتي اونلاين؟
وتغير فحصي قبل بيومين، تغير النهار وتغير من مركز
لا لا
لأنت.
لا خلاص، اصل القصص دي اتلغت خلاص، ما عادش فيه
إن شاء الله.
خلاص. هي بس كانت حلوه للناس بتوع الاوسكي، كلهم عاملين ينجحوا في موضوع الكوفيد.
ليش عملوه أونلاين كمان الأوسكي؟
لا لا، بنسبه النجاح كبيره،
أوكي.
كل اللي دخل
بدهم
اوسكي بينجح.
صيادلة، لأنه بدهم صيادلة بتخيل.
هم بدهم ناس عشان الفاكسين وخلافه، نجحوا يعني دفعه 11 2020 كل الناس نجحت، كل الناس نجحت. واللي
أوكي.
دخلوا في واللي دخلوا 2 21 نجحوا، واللي دخلوا في 5 21 كلهم نجحوا.
I know, I know one of my colleague, it's very smart and very organized. She didn't pass OSCE last wave.
مين ده؟
one of
اتكلم
my
عربي
colleague.
يعني. تقول ايه؟
واحدة من اللي أنا أعرفهم يعني، لا مذاكرة كويس جدا جدا وما عدتش الويف اللي فاتت من الأوسكي.
يا شيخ،
يعني
رغم ان كل اللي انا اعرفهم
مستواها
نجحوا.
رائع. أنا كل اللي أنا
كل اللي
أعرفهم
انا اعرفه
ناجحة برضه، بس هي شيماء دي لا يعني ما شاء الله مستواها لا معدي أي حد أنا ممكن أتخيله، بس ما أعرفش ليه
انا
ما
عاوز اقول
عدتش
لك كل اللي انا اعرفهم كان مستواهم وحش جدا ونجحوا، انا مش عارف ازاي.
سبحان الله.
انا مش عارف ازاي بجد، مستواهم ضايع يعني ونجحوا.
الحمد لله على السلامة.
هي
وشيماء ما
بنتكلم
الفكرة
في
نجحتش.
ال
شيماء ما
70
نجحتش. شيماء ما نجحتش.
نعم.
70 ولا ايه؟
هي يا
نعم.
باشا كده سامعين.
يلا بينا. انا اكمل
Uh,
عمراني عشان
we were
الموضوع.
we were talking
يلا يا سعادة
about
الباشا.
the preference of unfractionated heparin in after PCI in the STEMI.
Yes, yes. I believe
It's more preferable than the enoxaparin.
what setting, and if the creatinine clearance is below 30 or in all conditions.
Excuse me, say it again.
In what setting we prefer or we privilege the unfractionated heparin over enoxaparin?
I don't know, but I
Okay, so I believe
general enoxaparin if the creatinine clearance less than 30, so we will not use enoxaparin. But from the beginning, we will start with unfractionated heparin. If unfractionated heparin is contraindicated, we're gonna go to the enoxaparin as alternative. Is it true?
no, I don't think so.
Really?
No,
Okay.
yeah, I don't think so. I believe the enoxaparin could be the preferred agent. If the
So
creatinine,
enoxaparin in STEMI and non-STEMI? Enoxaparin is the preferable agent?
yes, where is the unfractionated? Yes, I believe so.
Okay, thank you.
That's it.
Okay.
تمام. Okay, so we have to go anticoagulants as we said. Yes, so need to use the anticoagulants post PCI in STEMI. Here should be administered for at least 5 days in low-risk patients. What does it mean in low-risk patient? If the patient is treated medically. If the patient is treated medically, we should give the anticoagulants for 5 days, at least. Okay? The same thing here. Tamam? Okay?
Okay.
Perfect. Complications of STEMI will be heart failure, arrhythmia, death, can progress to STEMI in case of non-STEMI. Yes, it could progress to STEMI, but this is rare. And the same thing for unstable angina, progress as well to STEMI. And I believe it's very rare as well. Tamam? So, done like a table for some major differences between the three conditions: Steemian and stable angina. Here, the Stemi score. I believe we are عيني كده ولا ايه؟
دكتور الصوت كان بيقطع خالص، احنا ما سمعناش ولا كلمه من حضرتك قلتها.
انت سامعني كده يا ارمي؟
انا كده سامع حضرتك، بس الاول ولا حاجه حصلت. يعني احنا كنا سامعين صوت عمال يروح ويجي، بس ولا حاجه خالص.
Okay, what I was saying that I think we are fine with the STEMI and non-STEMI. Do you have any specific questions about the STEMI and non-STEMI? Like the treatment, etc., the management,
Yes,
differences?
I have a question for the high risk patient. The high risk patient, after I make CAPG or PCI, when I go to the ABCZMAB and eptifibatide, when I use this agent,
When you use what? Which medication?
with the high risk patient after
Yes.
CAPG or PCI, after revascularization.
Yes, okay.
We have to give the patient ABCZMAB or eptifibatide or tirofiban. Is it right? For any patient or
I
for a
think
specific one?
No. Who said that? It's not for any patient. For what? I think it's a... No. From where did you get that? It's a... Hello?
Yes.
ايوه يا باشا.
No.
Yes.
ايوه يا باشا.
From where did you get that?
PharmaSpirit. PharmaSpirit
No.
they write it like it will go for CAPG and PCI.
No, it's they are not first choice at all. They are not the first choice. The cost is number one. They are very expensive. Number one. Number two, they do not bring extra benefit over the other agents.
Okay, so my question is, what is the
So
benefit of this agent? Is this agent like to increase the immunity or what?
No,
for the
Absiximab, we can use it.
Yeah, Absiximab.
For no, we can use it like anticoagulant. No, they can use it like anticoagulant. Let me check here. Let's see the CTC, but as much as I know, yes, we can use it as anticoagulant, but it's not in practice. No, we don't use it. We don't use it at all. They are not recommended. They are not a first choice at all. Wait.
In this Stemi school, what is 2 for, doctor? It should be 24 hours for angina before.
معلش ما سمعتكيش. What's the question?
What is 2 refer to? In Stemi school, 0.5.
Yes,
for
2. It's
ACTA.
2. Yes, 2 angina attack within the last 24 hours.
It should be 24. Is it right?
Yes, 24 hours.
Okay.
There's even mentioned here. Acute coronary syndrome. It's not mentioned here, right?
No.
So
I think I'm sure I read it in CTC too. That's why I pick it with highlighted.
Yes, maybe yes. Abciximab, we can. I think we can use it in some settings like anticoagulant, like an
But my
antiplatelet.
question is when I use it, in which case?
No, I don't know, but I believe if there is a contraindication for the conventional agents, because we do not use them at all. They are, as I said, they are very expensive. Maybe the safety profile as well. They can cause side effect, adverse events more than the others.
Yes, thrombocytopenia.
Of course, yeah, they are not bringing an additional benefit over the other agents. So it's for me, it's really bizarre, but we can check as well the up to date to be. Can you see my screen?
Yes.
Can you see the browser?
Yes.
The browser.
No, we can see only the slide
No.
of two,
Up to date.
the Temi screen.
Timmy. Okay. I think you can
Now,
see it
yes.
now, right?
Yes.
Okay, let's do it. What's the name? Abciximab?
PBCI.
Vixix, I think.
Yes.
Yes, Abciximab. Here it is. Erythropoietin. Yes. It says it's antiplatelets who didn't undergo revascularization. Silent Abciximab, acute myocardial infarction patient with diabetic. We can use it with the patients. Has been evaluated in patients with acute coronary syndrome and in those undergoing intracoronary stent implantation, dual oral. Yeah. Yes, I don't think they are not first choice. No, they are not first choice. Okay. Yes.
Okay.
I don't believe they are not first choice. ما حدش بيسأل عليهم أصلا. As I said, they are very expensive. They have a more serious side effect than the conventional treatment. There is no extra benefit. But okay. تمام. Okay. Let's now proceed with the DAPT, Dual Antiplatelet Survey Guidelines. What do you know about the DAPT or Dual Antiplatelet Survey after the PCI? Okay. The recommendation here of the DAPT is very important. This is the guidelines, the Canadian guidelines. We recommend DAPT, Dual Antiplatelet Survey, with aspirin, with either ticagrelor or prasugrel. These are the recommended agents. Once daily over clopidogrel 75. We discussed that already, correct? So ticagrelor
Yes.
or prasugrel post myocardial infarction are the recommended over the clopidogrel. Usually we give dual antiplatelet therapy. For how long? For at least 1 year.
Yes.
Okay? Then we can make an extension. I will give you this chart is more it's more easier and simplified than the other one. Okay, so we give DAPT with aspirin, ticagrelor or prasugrel Okay, for 1 year. After 1 year, we make like an evaluation. If the patient have a high risk of bleeding or no. If there is no risk of bleeding, so we will continue DAPT for extra 3 years. But what are the agents here? Aspirin, ticagrelor, clopidogrel. What is the difference between the initial DAPT and the extended DAPT?
The dose of ticagrelor.
Yes, this is number one.
Because in the initial we give, I think 90 milligram.
Yes.
The second 60. Second
Exactly.
60.
Exactly. Ticagrelor.
Twice daily. Yes.
Always twice daily. Always twice daily. Clopidogrel aspirin only once daily. Prasugrel as well, once daily.
Yeah.
Okay.
Yeah.
Ticagrelor always twice daily. The dose is changed from initial DAPT, it will be 90 milligram twice daily. For the extended DAPT, it will be 60. Number two, the difference between extended and the initial DAPT will be the recommendation of clopidogrel. Clopidogrel is second choice or not recommended in initial DAPT, while in the second or the extended DAPT, it will be recommended here.
Yeah.
As first choice. Okay. This is if the patient has low risk of bleeding. What if the patient would have a high risk of bleeding? We will go only with single antiplatelet therapy. And it will be aspirin or the clopidogrel. Okay?
Yes.
So the clopidogrel is recommended. One moment. Okay, my friend. So is it clear?
Yes, sir.
Amen. For high risk, yes. After 1 year, yes, we give the single. If for high risk patient of bleeding, we give SAPT, which is single antiplatelet therapy. Okay, تمام. Okay, perfect. Very good. So this is a different recommendation. This is for what? For STEMI or non-STEMI? PCI for STEMI or non-STEMI? In acute coronary syndrome recommendation. And this is very important, guys. Okay, you will have here some recommendations as the same thing. Okay, do you know what does it mean with a patient in high risk of bleeding? What criteria we have to decide if this patient would have a high risk of bleeding or no?
The age.
What are the criteria?
The age.
What is the age?
If it is more than 75, it's high risk of bleeding, more than or equal.
Yes. Yes.
And the weight, if it is less than 60.
Yes.
And the previous stroke at the last year. And the head trauma or active bleeding excluding the menstrual cycle.
Active bleeding.
Yes.
Okay, this is a contraindication. This is I think this is a contraindication to the fibrinolytics, right?
It is a contraindication for the antiplatelet due to the high risk of bleeding if used as antiplatelet.
Okay. يعني more or less okay, but usually it's the age of the patient, as you said, 75 and above, and if the patient has chronic kidney disease, Create clearance is less than 30, I think. Okay, and the weight 30 or 40, I think something like that. The create clearance. And the weight, if the patient weighs less than 60 kilograms, if the patient has a history of the active bleeding within the last year, okay, and if the patient has anemia or hemoglobin level less than 100 or 110. تمام? Usually these are the criteria on which we measure the risk of bleeding for any patient. تمام؟
معلش نسبة تاني يا دكتور بسرعة كده الهاي ريسك بليدنج كام بوينت الخمسة تاني معلش
age above 75 years, weight less than 60 kilogram, anemia or hemoglobin level less than 100 or 110. تمام. Chronic kidney disease, create clearance less than, I think, 40 or 30 milliliter per minute. What else? Yes,
active bleeding.
active bleeding. Yes, active bleeding or GIT bleeding, and etc. And yes, if the patient is taking other medications like the cortisone, like prednisolone, or NSAIDs, if the patient is taking that at the same time, the other medication that may increase the risk of bleeding, like NSAIDs, prednisolone, or any other medication. تمام؟ اوكي سامعني ولا ايه عشان انا
يس ايوه يا باشا ايوه يا باشا زي الفل كمل يا باشا.
Very good, very good, very good, very good, very good. Okay, here we have the recommendation for the elective PCR. Okay, if the patient would be prescribed antiplatelets in a setting other than acute coronary syndrome. For this one, this in the case of acute coronary syndrome, correct? We have STEMI or non-STEMI acute coronary syndrome. Here, the setting, if the patient like for is doing stenting, لو بيحط stent دعامة. Okay, what would be the recommendation for antiplatelet to prevent the stent thrombosis, for example? Okay, so we have the same criteria, not at high risk and high risk of bleeding. If the patient is not at high risk, we would recommend DAPT, dual antiplatelet therapy, for 6 months. The recommended here is aspirin with clopidogrel. So here it is. We have another difference than the other recommendation. You see the difference? This is an acute coronary syndrome. This is in the other settings like a stenting or any other setting at which we should use dual antiplatelet therapy other than the acute coronary syndrome. تمام? And you will follow the scheme, but the difference here. Yes, Armin, سامعني؟
الصوت بس ده معناه انه لسه ما عملش البي سي اي هيخش يعمل البي سي اي مش كده؟
لا ده في setting مختلف عن الاكيوت coronary syndrome. I'm here talking about the dual antiplatelet therapy. For this chart, it's talking about the dual antiplatelet therapy in acute coronary syndrome setting. لو البيشنت لو عنده acute coronary syndrome. Here, if the patient is having another condition than acute coronary syndrome, the patient does not have acute coronary syndrome, but has other indications for which he has to take dual antiplatelet therapy.
غير الاكيوت كوروناري سندروم مش كده؟
Yes, غير لو هيعمل ستنت مثلا هو بيركب دعامه بيعمل اي حاجه ثانيه مش لازم يبقى عنده acute coronary syndrome. دي هتبقى recommendation.
تمام.
Yes. Okay. You can read it. You can read it as well. but there is a difference. Clopidogrel is recommended here. Okay, so usually, in a nutshell or in conclusion, we can say that ticagrelor, prasugrel are recommended post myocardial infarction. In other settings, usually it's clopidogrel and aspirin. Do you remember the setting in angina, stable angina?
Yes.
Yes, we said which one is recommended?
It is aspirin, and
Clopidogrel.
if it's allergy, no, it is aspirin first. And if it is aspirin not recommended or contraindicated, you can use
Clopidogrel
clopidogrel. This is in the stable angina.
or ticagrel.
Okay.
ما فيش تيكاجرولول خالص في الانستيبل في الستيبل انجينا
لا لا في
بعدين
في
هي بعدين
مفيش.
في بس بعدين. First is aspirin, second recommended is clopidogrel. Afterwards, we can go with ticagrelor, yes, and prasugrel as well. Okay, this is correct. Okay, but here in stable angina, do we give single or double antiplatelet therapy?
single.
In stable, single.
Perfect. Good. Very good.
Ticagrelor can taken in prevention secondary.
Yes.
في الستيبل صح؟ Okay, Doctor, all these slides will included in our new material on
Yes.
the platform.
Yes.
Okay.
Yes.
Thank you.
You will have here an interesting switching between APIs. How to switch between the antiplatelets. There's a technique, just read it. It's an interesting one. Okay, you will have some notes here. Prasugrel should be avoided in patients with previous TIA or stroke. Clopidogrel in STEMI or non-STEMI after PCI is not preferred, while it's preferred antiplatelet after fibrinolytics in STEMI. Here it is. Okay, so it's not preferred generally in acute coronary syndrome, except after fibrinolytics in STEMI. It would be preferred here.
حلوه الحته دي.
تمام. In patients with STEMI who receive fibrinolytic therapy, prasugrel should be avoided in patients with previous transit. Okay.
So you mean I can use the clopidogrel only after altiplase?
Let's repeat.
I can use clopidogrel just in case I use altiplase.
أيوة
Only
كلام.
after
Here,
altiplase
here.
صح؟
It's
Even
preferred
here,
مش only. It is preferred.
It's preferred. So, in fibrinolytics, after STEMI,
Yeah.
do we use single or double or dual antiplatelet?
Say it again. Say it again.
Okay, here, if we treat the patient with fibrinolytics in STEMI, should we give the patient afterwards a single or dual antiplatelet?
Single.
Single. يا خسارة اللي قلناه يا دكتور رنا.
دبل يا نهى، مالك ايه اللي حصل لك؟ دبل.
لا خلاص نعست بقى.
After both myocardial infarction.
نعست بقى.
هي تعبت، هي معلش هي تعبت.
Myocardial infarction, my friend. Yes.
أفواه وأرانب عايزين يتغدوا.
بصراحة احنا بقالنا 4 ساعات فكده كفاية، هو كده أنا خلصت خلاص. بس here just last information. Post myocardial infarction, always it's dual. It's dual antiplatelet therapy, except in high risk patients of bleeding. If there is a high risk of bleeding, we give only single. But usually, for most of the cases, it's always dual antiplatelet therapy post myocardial for 1 year, and after 1 year we will make like an evaluation if the patient will need an extension with dual antiplatelet therapy, or we can go only with single antiplatelet therapy.
Single. So is there any cases he can take more than 3 years?
No.
Okay.
For aspirin, he may use it for lifelong. For life
Yeah,
for
I know.
yes. For
No, I
aspirin,
mean the
yes.
dual one.
Dual,
The dual.
no. We have only recommendation for 3, up to 3 years. تمام؟
تمام
تمام يا
جدا.
باشا زي الفل.
I think we are done now. كفايه بقى بصراحه كده، هرسنا هرس.
دكتور بعد اذنك، بص انا عاوز اقول لك على حاجه، خلي بالك الكلوبيدوجريل بيستعمل بعد الفايبرينوليتكس عشان الريسك اوف بليدنج، عشان المريض ده بيبقى واخد التي بليز، فبنديله كلوبيدوجريل عشان البريزيجرول والتيكاجرول ليهم ريسك اقوى بكتير
ريسك فور
مور
بليدنج عالي.
من الكلوبيدوجريل. حبيت اقول
تمام.
لك